I'm Harriette Van Spall, clinical trialist from Canada, and I'm so delighted to have with me Professor Stefan James, who is a principal investigator of the SWEDEGRAFT trial. And we are here at ESC 2024 to discuss the exciting, impactful findings from his trial. Welcome, Stefan.
Thank you, Harriette.
Tell us what no-touch vein grafts are.
Yeah, so that was a technology to harvest veins from the legs to implant on the heart for coronary artery bypass surgery by a Swedish cardiovascular surgeon. He thought that if you take more of the surrounding tissue around the vein before you implant it and handle it very carefully, not distend it too much with saline, you would prolong the survival of the graft, the patency. And so that idea he has tested and others have tested and found some interesting findings that in small trials it appears to be faring better. It improves patency by handling it more carefully as compared to the standard technique in which you strip the vessel, ligate all the side vessels, and then flush it with saline.
Okay, and what was your trial aim?
And so we wanted really to test this in a sufficiently large power trial to see if it actually helps patients. And so we set up this 900 patient randomized trial to test the hypothesis. We had several important endpoints. The primary endpoint was CT angiography at least 2 years because we wanted long-term follow-up because that's important for surgery. And we wanted to look at graft patency. So we assessed CTA at more than 2 years as part of the primary endpoint. But we also included in that primary endpoint if the patients had undergone PCI in the vein graft or in the native vessel proximal to the distal anastomosis of the vein graft, or if they had died. But importantly, we also wanted to look at long-term clinical outcomes, which is important to patients. More than 4 years post-operation, we looked at any death, any myocardial infarction, or any revascularization. And then we also looked at safety endpoints. So we called the patients at 3 months, checked if they had any complications from the wound, antibiotics, etc. And then furthermore, 2 years, we looked again how they feel, symptoms, quality of life, etc.
All right, and what were the eligibility criteria?
So any patients below the age of 80, so we want to keep them a little bit younger in order to be able to follow them for a sufficiently long period of time. But then any CABG expecting the need for at least one vein graft.
And tell us about the baseline characteristics of these patients. Were they balanced in comorbidities that could potentially affect graft patency?
They were very much so, very balanced, and really reflecting the true population of everyday clinical practice. Thanks to the fact that we performed this as part of our registry. So all data were automatically transferred, baseline characteristics, procedural characteristics, and outcomes from our registries. So the mean age was 60, 65, 67, predominantly male. Half of them had ACS as an indication. A third of them diabetes mellitus. A fifth of them had prior PCI. So clearly reflecting clinical practice. And they were also very well treated pharmacologically. Virtually all of the patients were on aspirin. More than a third were on potent P2H12 receptor inhibitor, predominantly ticagrelor. Almost all of the patients were on statins, beta blockers, and AC inhibitors, etc.
Okay, and tell us your primary results.
So the primary results was interesting. It did not meet the primary superiority endpoint. It tended numerically to go in the right direction in favor of this technique. And the primary endpoint was driven completely by the CT angiography findings. So biologically, it appears that there is some signal of benefit, but it did not reach far from clinical superiority.
And were your event rates adequate?
That's a good question. We based our power calculation on several previous trials. Typically, in many of previous trials, there is an event rate of 50 to 20% something of graft patency. That's typically per graft, not per patient. It's also typically at 1 year follow-up, and it's typically based on a stenosis rate of at least 75%. We based our assumptions on a longer term follow-up and a per patient analysis, not per graft. And we also had a more strict definition of stenosis or occlusion. So we thought it was appropriate to say that probably 50% of them would have at least one vein graft failure after 2 or 3 years follow-up.
And how did you account for surgical technique, surgeon, center, some of those higher level
Very
factors?
In these types of trials, of course. And so this was invented in Sweden, so all surgeons have experience with it. But still, we made very clear instructions and how do we define this technique versus the other technique. So very strict, define the instructions to them, including a film, how to do it. They were all experienced with it, but also in order to be able to understand and make sure that this did not affect the results, we also made post hoc different types of analyses, looking at the experience rate, checking those centers who had this as their default technology before the trial versus a selected strategy before the trial. We also compared hospital to hospital, surgeon to surgeon, and there was no heterogeneity or interaction based on those.
Okay, and why didn't you have a patient-reported outcome there?
That could be done also. It's an open label trial, and so you have to be a little bit careful with open label trials and patient-reported outcomes. But we do have more information that we have not analyzed yet, so there's more to come.
Okay. Share with us some of the secondary results and the safety events.
Yeah, so that is a very important part of it, because the MACE event rate did not have any signal of superiority. The hazard ratio was 1.3, actually going in the wrong direction for death, MI, and revascularization. And it's important to point out that the event rate was very low, good for the patients, very low mortality, in fact fairly low rate of repeat revascularization as well. So good for the patients, but no signal of benefit with this technology.
Okay.
And even more importantly, the side effects, they were very much increased, significantly higher in the no-touch graft group as compared to the standard technique group.
Okay, and how did you measure side effects?
So we called the patients at 3 months and asked, did you have any issues with your leg? Did you visit hospitals? Did you take antibiotics, etc.? And all components were about twice as high in the no-touch group versus the standard group. And then at 2 years, we did a second follow-up, and we asked for symptoms, both angina, but also symptoms from the leg, sensitivity disorder, pain, swelling, etc. And those were also significantly increased in this group, no-touch group.
Okay, so how do you put your results in context of the prior evidence and current guideline recommendations?
So you know that this is something that is recommended strongly by the ESC guidelines. It's a 2A, level of evidence B recommendation. So something you should consider to all patients, in which you do an open harvesting. And so fairly strong recommendation based on fairly limited data. This, I think, tells me that there has some biological plausibility to do this, but it doesn't benefit patients. There's no clinical benefit in terms of death, MI, revascularization. There's no benefit of symptom relief, but there's significantly more complications. So I think that needs to be downgraded, to be honest.
Okay.
As if I was a patient, I didn't want to have anything that perhaps looks a little bit better on the CCTA angiography, but doesn't benefit me in terms of have a lower risk of myocardial infarction or repeat revascularization, but cause symptoms. Although I have to admit that these symptoms were not fatal, not very serious, but still pain, swelling, more antibiotics, more need for care, wound dressing, etc.
Well, Stefan James, thank you for sharing your time with us and disseminating the exciting results from your trial, SWEDEGRAFT. Congratulations on an excellent presentation.
Thank you very much.